All right, Paul.
Well, hello, everybody, and welcome. I'm Paul Terry. I'll be your host for another Hero webinar. And what you see on the screen is a brand new book that is going to be published in February. You know that the title of this webinar we called Creating Behavioral, Environmental, and Policy Change. And you can see now that we just stole directly the subtitle of this new book that we have one of the editors along and another expert in this area of health program planning, implementation, and evaluation. Is going to be coming out as the first edition under Johns Hopkins University Press. But those of you who are formally trained in public health know this is about the fifth edition of a book that has been a staple in the field of public health education training for many years. I am very excited to introduce our two guests today, Andrea Gielen and Mary Imboden. But before I do that, let me tell you why I'm so excited that this planning paradigm is being released yet again with all manner of new iterations of the research and planning that goes into this use of this pre-seed, proceed tool that Dr. Gielen is going to talk about. Let me preview this webinar by sharing some HERO research that Mary Imboden has been a leader in. We looked at the 2,000 plus companies that have filled out the HERO scorecard. We took a subsample to study this question about what's the connection between those who have written strategic plans and the kinds of outcomes that they're able to report in terms of the value and benefits of their employee health and well-being initiatives. Listen to this, you guys. 70% of the companies who say they do formal multi-year written strategic plans, 70% are able to say then that we see positive health outcomes. 21% say significant health outcomes. 49% say slight improvement in health outcomes. But anyway, 70% are able to say we have a written plan, we see good outcomes. Now, what percent of companies who say they don't have a strategic written plan, a formal approach to health planning, are able to say that they have positive health outcomes going on as a result of their employee health and well-being? Well, that is 6% of those who say they don't have a written strategic plan are finding an association with health improvement outcomes. Why is all of those obvious contrast about the benefits of planning important? Well, Mary and colleagues did another study that said, well, what is the total proportion of organizations that actually do a good job of strategic planning? 44% of companies have no written strategic plan. 25% of companies have a multi-year strategic plan, meaning 75% of companies don't have a multi-year plan, and only less than 47%, even of those who do their planning, feel that their plan is effective. So this is really a big deal topic, and we come back to it, as you know, at HERO often, just the importance of planning. So that's why I was excited to be invited to be part of Andrea's team in drafting this book. I, along with many of you know, Nico Pronk is a really important researcher in the field of worksite health promotion, and Shelley Golden, a really big deal academic at University of North Carolina. They joined me to do the occupational settings chapter of this new edition of health program planning. And so I get quite excited about the fact that this tool, this pre-seed, proceed planning framework, has a good track record of supporting worksite health promotion generally. When we want to get specific, then we look to the real big deal experts that are leading the charge on this book. And I am just so pleased, Andrea, to have you join us for a HERO webinar. You are a professor at Johns Hopkins University. You're affiliated with everything good and great going on in the school of Bloomberg School of Public Health, Health Behavior and Society, Health Policy and Management. You've been the director of their Centers for Prevention of Youth Violence and Injury Research and Policy. I won't go into your bio in too much detail. I can't resist jumping to your honors and awards because there is no recognition in the field of public health and health promotion that you have not earned over your very robust career. The Elizabeth Fries Health Education Award from CDC, Distinguished Career Award from APHA, Award of Excellence from American Academy of Health Behavior. And as you can see, this goes on and on. Similarly, if you do as I do, and I'm trying to assess the kind of expertise that I'm about to interact with, I always jump to PubMed and see what they're working on. And your portfolio is inexhaustible. You have been publishing important papers. And what I really notice Andrea, that sticks out for me, that how often you've been the first author of these studies, first author of these papers. You are absolutely tireless in your work in all things injury prevention and safety. If you look through her 17, 18 pages of articles, you'll see she's talked about seatbelts, she's talked about car seats, she's talked about domestic violence, sexual assault, pill dispensers. There's nothing. And when I say nothing, I mean nothing she's not studied. Here, for example, she even studies walking. You can't get past Andrea with respect to what she's interested in. So I actually would commend this. This has been around for a while, since 2014, but there's really, she's just going to give you a teaser today of the kind of stuff she studies, you guys. If you want to see her do a full hour lecture on how to apply something like walking, pedestrian safety, to the kinds of public health issues that she studies deeply, just Google actually Andrea Gielen and put her on the video setting, and you'll see she's done a lot of public discussion, but this one is really quite a fulsome one. Also, for those of you who aren't going to run out and get the new health planning book right away, I always try to put you on to other materials you can find. University of Kansas, as it turns out, did a very exhaustive analysis of how to put pre-seed, proceed to work in community health planning. So just put in your Google search engine, pre-seed, proceed, and community tools or toolkits, and you'll see a very thorough rendition of how this planning framework rolls out, including sort of some of the illustrations that are often used. Joining Dr. Gielen today is our own Mary Imboden. All of you know Mary from HERO. You may not know that Mary doesn't work full-time just advancing health promotion via HERO. She is also the chair of the Department of Exercise Science at George Fox University, assistant professor there in exercise science as well. Those of you who know Mary know that in addition to her work in exercise science, she's been quite a researcher. She was a Wake Forest coordinator for their school's health and exercise science program, exercise specialist in North Carolina as well. But you know her work at HERO as not only director of our research activities, but she really is the advocate and promoter of the HERO scorecard developed in cooperation with Mercer, that she's the head of our HERO preferred provider network, all of the researchers around the country that really want to use the scorecard. So you're going to see her following Dr. Gielen's presentation soon with how it is that the HERO scorecard really is one of those tools that helps those of you who are doing comprehensive planning go ahead and use those tools to good effect. So Dr. Gielen, we're going to put you up first, and you'll see that as much as Dr. Gielen has a very robust focus on safety, as I said, and community work, we'll talk together about the overlaps between the private sector and her work in the community sector soon after this presentation. So Andrea, thanks a ton for joining us. And you're on mute right now, Andrea. We'll have you come off mute.
Yes, okay.
There you are.
Right. Always something. Okay. So thank you very much for that wonderful introduction and the invitation to be here. I'm embarrassed, but I will say now, I guess everyone in the audience knows why my children call me a safety nerd. It is true that I'm very passionate about all things injury. And I hope to share a couple of examples with you today on that topic and how Pre-Seed Proceed as a planning tool can help in putting together good programs, whether you're addressing an injury problem or any number of health problems. So you've seen our new book, and we're very excited to share it with you and this distinguished list of authors who were kind enough to join us on what was a 3-year journey to recreate, update, and expand on what we know about Pre-Seed Proceed as a planning tool for health promotion programs. The new book is divided into 3 sections where we talk about some of the history and hallmarks of the model. We go through how to actually use it in planning, implementation, and evaluation. And I would say that the evaluation chapter and materials are new to the book and a great addition. And then we have the applications in the various settings that include occupational settings with our own distinguished Paul Terry, which we're very grateful for him and his colleagues for having added to the book. Also new are some frequently asked questions. I've taught this model for a long time. And my colleagues and I frequently get the same questions from students who are anxious to learn how to use the model. So we've added something to answer those most frequently asked questions. Public health competencies and requirements have changed. So we now can link the content of the book to what those competencies are. So for any of you in public health academic settings, that will be very useful. And then finally, as I mentioned, much more on the evaluation tools. So to give you a flavor for how Pre-Seed Proceed as a planning tool might be helpful to you, I'm going to run quickly through 2 examples from my own work that have to do with injuries. One in a community setting working with a state health department, and another one in a healthcare organizational setting, which is a pediatric primary care program in Baltimore. And if you're wondering why injuries, I always have to share this chart because many people don't realize the impact that injuries has on our country. These are the 10 leading causes of death by age group in 2018 from the Centers for Disease Control. And the blue boxes, or the top row from ages 1 to 44, are unintentional injuries. The green boxes in the second row from ages 10 to 34 are suicide. And the red boxes, most notably in the third leading cause of death for 15 to 34-year-olds. This represents the enormous impact that injuries, both intentional and unintentional, have on our society, which is just one of the reasons that I was fortunate to have an opportunity to work in this field. And the good news about injuries is that we know how to prevent many of them. We know how to prevent deaths to little ones by using car seats in motor vehicle to prevent motor vehicle crash deaths. And home injuries are also a problem. Both fatal and non-fatal. The home, while we think of it as our safety place, it's often a cause of many kinds of injuries, such as falls, burns, and poisonings. And so our challenge is to effectively promote the dissemination and utilization of these proven effective interventions. And you may feel the same way about what issue you're working on, your health problem. You know how to help people, but how do you get them to take up your prevention interventions? And that's why we need something like Pre-Seed Proceed. So let me start with we have to go back in time for this, but I think it's still relevant today. This is the problem of car seats use in the state of Maryland. What I'm sharing goes back to before we had car seat laws and before we had federal standards on car seats. So it goes back a ways. But the point is that using a model like Pre-Seed Proceed was extremely helpful in building a program for the state of Maryland. And what you see here is part of the model where you focus at the end. What is it that you want to get to? We want to improve people's quality of life by addressing their health problems. And in this particular case, we were talking about reducing motor vehicle child occupant injuries and deaths in the state of Maryland. That's a big health objective, but breaking it down to what behaviors and what environments are responsible for those motor vehicle child occupant injuries and deaths is what Precede helps you to do through the planning process, which you see highlighted here. So we work from right to left, engaging our audience, understanding theory, understanding how to make change, and we identify the behavioral and environmental factors that contribute to the problem we're interested in. And in our case, we wanted to increase the proper and consistent use of car safety seats by making their use required by law and making seats available to people who couldn't otherwise afford them. But that it's not enough to just stop there and say, okay, I'm going to just tell people to do this behavior and I'm going to put the car seats in the stores. Obviously, you all know that it's not that simple. And so Precede helps us try to understand those determinants of the behaviors and the environments that are at issue. And you can do that any number of ways. But what happens with this model, which is one of the really great things, is it organizes your thinking. So we talk about predisposing, reinforcing, and enabling factors. And the predisposing factors are the things that we think and know and believe. In our case, we did surveys, we talked to parents, we looked at the literature, and we said, you know, this is, again, back in the day before we had everybody using car seats. We found that parents really were not aware of the need for them, and they had a lot of misperceptions about whether their kids would, in fact, be comfortable in car seats or even be safer. Reinforcing factors, it's not enough just to have parents know what they should do and believe they want to do it. They have to be encouraged to do it. In this case, they need to hear from their pediatricians, the grandparents, their friends, that really car seats are the thing to use. And then thirdly, they need to be enabled to take an action. And in this case, we had two important things going on. We had to educate legislators to say, we know that mandating car seat use works. It's going to get more kids safe and protected. So we need to have a law in our state. Other states do have a law. And we needed to reduce financial barriers to using car seats. You certainly don't want to mandate something that a large part of your population can't afford or can't take action on. So this was the assessment, the diagnosis that led us to build a program. And I like this example because we used Precede so well, and because I get to show you my cute child back then, who's now probably 40 something, I think. But anyway, yeah, we didn't even have color photography back then. But this is the program that we came up with. We had we worked with our legislators to pass the law. We got car seats out and we showed people how to use them and why they needed to use them. And what that breaks down into the health promotion program is a comprehensive strategy that addresses predisposing, reinforcing, and enabling factors. We provided training and resource materials for health departments and other significant others like physicians, community organizations, and the police. We educated the public with educational materials. In order to pass legislation to mandate something, we had to get community support. And we did that through creating and supporting child passenger safety associations and creating car seat loaner programs to make those car seats available. So this is one complete quick look at a program that was built using Precede Proceed. And some of the things that we've learned since then with regard to implementation, and this again is highlighted more in the book, is that it's all well and good to put those plans on paper, but think about what is needed for successful implementation. We know that any education has to reach your audience with appropriate information that they understand and believe. If you're going to have a mandatory component, it has to be widely known and understood. It has to be perceived to come with a high probability of enforcement and swift and severe punishment or strong incentives to comply. And in our case, and maybe for you in other examples, there's a technological component. And if you have a technological component, in our case, it was the innovation of new car seats. They have to be effective, reliable, easy to use properly. So those are some of the things that we needed to think about in the implementation phase of our project, Kids in Safety Seats. And last, oh, not quite last. Well, if you believe that these things are all necessary for successful implementation, pre-seed proceed makes you ask, well, who is at the center of all these musts? And the answer is your audience. Going through this pre-seed proceed process is not something you do in your office with the door shut and talking to one or two of your friends, obviously. You have to know what your audience is thinking, believing, and wanting to do. And so we believe, and the model helps you make sure that you sort of plan accordingly, is that we have to understand and respond to what our audiences think is important. And why? Because it's pragmatic, it builds better programs, and it's ethical. The things we ask people to do are not always easy, and we believe very firmly in this country in individual autonomy. And so we have to adhere to that. We have to bring our audience along with us and make sure that we're building a program that's acceptable. So the bottom line is involve your intended audiences early and often. In terms, last one on this is evaluation, and this is national data. I want to share the data on the impact of improving child passenger safety through the uptake of car seats. And in the country, from 1975, these data end after 2017. You can see this is by age. So the blue line is the under ones, and then the 1 to 3s, and the 4 to 8s, and the 9 to 12-year-olds. And you can see in every case the impressive downward trend in lives saved as a result of increasing car seat use. So that's an example from working out in the community. And the second and final example is working within an organizational setting. And this is a healthcare setting in Baltimore. It's a pediatric primary care residency training program in Baltimore. And it's the Safe Home Project. One of the things we first learned about that set this project in motion is that our children who were served in this clinic were primarily on medical assistance, and they were experiencing injuries at twice the rate of the national average. And so many of those were home injuries, and many of those, as I said before, are preventable. And that was the health problem we were set to tackle. And we found that, again, the organizational context was huge, as you'll see as we go through this. But one of the first things about the organizational setting was that these were pediatricians being trained to go out and practice. And there really wasn't anything in their training program on how to prevent home injuries, despite the fact that injuries, including home injuries, are the leading cause of death for children. So they partnered with us in the Injury Center, the Department of Pediatrics. So remember that as an example of sort of the Department of Pediatrics. We couldn't do this just because we were passionate public health people. We obviously needed the organizational support of the Department of Pediatrics. And so here's our friend again, Pre-Seed Proceed, where we look at the quality of life indicators for families with children. Parents want to have their kids grow up to be healthy and successful and certainly not injured. And we were specifically interested in reducing child injuries from falls, fires and burns, and poisonings. But again, those are each very big topics. And so what were the behaviors underlying that? And what were the environmental factors underlying that? Again, through our planning process, we talked to parents, we looked at the literature, we looked at what the American Academy of Pediatrics recommended, what was the evidence, what was the Department of Pediatrics and the hospital, the clinic setting, willing to do. And we landed on stair gates, baby walkers, smoke alarms, hot water temperatures, and poison storage as the behavioral factors that we wanted to intervene on. And one of the things we learned from parents is that they didn't have access and they couldn't afford many of these safety products. So that was part of what we were going to have to address. Again, looking at what predisposing, reinforcing, and enabling factors were at play, we found that through surveys and interviews that parents really didn't think that their kids would be seriously injured. And if they got injured, it wouldn't be that bad. And besides, there were a whole lot of barriers for them to get a stair gate or to put up a smoke alarm. In terms of reinforcing factors, we found, listening in on a bunch of many child visits, that pediatricians weren't really talking to their parents about the need for these things. And finally, as I said before, we found that they really had all of these products that we recommend, like stair gates and things to store your poisons in safely. They can cost a lot for families with limited incomes. So what to do? After the assessment, we developed a comprehensive strategy, again, that addresses predisposing, reinforcing, and enabling factors. And you can probably figure out, hopefully, from these program components, which of those factors we were addressing. The first one was a pediatric training program where we tried to enhance their counseling, their anticipatory guidance, by adding to their training program a specific way to counsel about injuries and injury prevention. We then built a children's safety resource center adjacent to the clinic, where parents could be referred to get free personalized education and reduced cost safety products. And this took a lot of organizational change work. So for those of you working in worksite settings, you probably can imagine trying to get a space dedicated, trying to get resources to staff it and to have the safety products in there. So that was another program component. This is a picture of the original Safety Resource Center. And then the third component was a community health worker visit to your home to identify hazards, to personalize education, help people if they wanted to install a stair gate, for example, and then let them know about the safety center in the clinic if they needed more help or low-cost products. So this is then the completed application of Precede Proceed here, and you can see we have the three components. The pediatric counseling program was shaping what parents knew and believed. It was also reinforcing what we wanted parents to do to protect their kids. The Children's Safety Resource Center was specifically designed to address the enabling barriers, but also could provide reinforcement because there was an injury prevention person staffing it. And it also provided low-cost safety products. And then finally, the community health worker home visiting program was to, again, address what parents knew, what they were able to do, and to reinforce their behaviors. So this is, I think, a good example of components that synergistically work to affect change in the causal pathway to get to the outcome that you want. And it also illustrates how different interventions work across these predisposing, reinforcing, and enabling factors. They all influence one another. So that was our thinking about it and our hope and wish. And we did a staged evaluation where the first randomized trial looked at if we just improved pediatrician counseling, what kind of outcomes did we get with parent safety behaviors when we went and observed in their homes. And what we found was that we did change pediatricians' counseling behaviors. They did more and better injury prevention counseling, and they had more satisfied parents. They felt their visit was more informative and they were more satisfied. However, in their homes, we did not see any changes in their safety behaviors. When we compared the enhanced counseling with going to the safety center and having a community health worker visit, we found that the combination of having better counseling from the doctor and going to the children's safety center actually resulted in improved safety practices in the home environment. There was no added benefit of the community health workers in this evaluation. And if we have time and you're interested, I'm happy to talk more about that. But in any case, it turned out to be pretty successful to work with the pediatricians to build a resource center and get parents in there. And the safety center is still alive and well, and the pediatricians are still being trained to provide better counseling. So what I want to sort of begin to wrap up with is to talk a little bit about ecological thinking. We hope that you see in these examples the idea of ecological thinking, that the behavior, whether it's wanting people to stop smoking or wanting them to buckle their seatbelts, those behaviors occur within contexts or environments that make it easier or harder for people to act safely and healthfully. And if we want to be successful in our health promotion and behavior change efforts, we have to go well beyond just sharing information or single strategy solutions. So the idea is that comprehensive programs address individuals and their environments, making the safer, healthier behaviors easier or the default behaviors. And this may not be new news to any of you, but I hope what is new and helpful is how using something like Precede, Proceed will in fact help you build those better comprehensive ecological types of programs. And this is just a summary of what I just said with a little diagram for anyone who isn't sure about the ecological thinking that I'm referring to. We're really talking about thinking about an individual within their significant others, their organizations, their communities, and their states. And this is the new and improved Precede, Proceed framework that is well described in the textbook. And you can see we've pulled out intervention strategies on the left here, intervention strategies, implementation strategies, and evaluation strategies. They are well described and lots of tools to help you with that. And conclusions about Precede. I think it's a process that helps you organize the vast amount of information that you need to plan a program. We talk about it as a linear process, but actually we think about all those steps simultaneously and iteratively. You can always use it more informally, depending on how much time and energy you want to devote or can devote to it. But always think about your program components in terms of what you want them to affect in the causal chain: predisposing, reinforcing, and enabling. And we think it's a flexible tool. We hope you'll find it of help. And I think finally, all of this strategic planning teaches us that two of the greatest virtues in life are patience and wisdom. And good luck. Hopefully it'll help you with your programs. So I'm going to stop sharing and happily turn it over to my colleague, Mary.
Hey, Andrea, just fantastic. As Mary gets set up, I can't help but ask about the director resigning from NIH. If I were to nominate you to replace Francis Collins to run the NIH, he's been in the news a lot this week, and in his interviews, he seems downright contritious about his observation that the vaccine hesitancy is as much perhaps a communications and behavior change problem as it is a policy problem. And you just did a master course and obviously needing to take a comprehensive approach. If you were the czar of NIH, I have to reflect on his recurrent comments this week that he wished he had funded more health communications research, and I love that as a health educator. Hooray! Yeah, of course we want see prevention as much as all the biomedical research that NIH has funded. But you just gave a master class in saying, well, Francis, it's not just about communications. What if you were to kind of give a pie in the sky research agenda elevator speech as our new director of NIH, what caveats would you add to Francis's observation?
Oh, what a question. Oh my goodness gracious. We'd all be in big trouble. I don't want to tell you about my chemistry and biology experience. No, I think the social and behavioral sciences, getting integrated into biomedical sciences is hugely important. And they've taken some steps in that regard, but obviously not enough as far as we're concerned. Yeah, I mean, I couldn't say it better than you. They need some strategic planning on health behavior change.
Yeah. Well put. Well, and in strategic planning, you emphasized a couple of times participatory research, bringing the audience along. You know who an expert in that is on behalf of HERO is our friend Mary Imboden. So I'm going to have her talk about not just how the scorecard integrates with your safety principles, but how it helps bring people along in this planning process. Mary, over to you.
Yep, thanks, Andrea and Paul. So Andrea discussed the pre-seed proceed model and the importance of planning in the evaluation process. The HERO scorecard is a tool that can be used in helping to plan and evaluate your health and well-being programs, which safety programs can and really should be integrated with. The HERO Health and Wellbeing Best Practices Scorecard in collaboration with Mercer can help you evaluate your health and well-being efforts and plan and prioritize your future initiatives, keeping in mind your audience, or in this case, your employees, and really bringing them to the table when you're taking the scorecard is a recommendation that we provide. The scorecard is a free online tool, if you aren't aware, that more than 2,000 companies have completed since its first release in 2006. And additionally, over the past 6 years, nearly 200 organizations have retaken the scorecard, enabling time over time analysis to evaluate progress in their efforts and the changing and emerging workplace health and well-being practices. So just an overview of the scorecard, it's divided in 6 sections, including strategic planning, organizational and cultural support, programs, program integration, participation strategies, and measurement and evaluation. And when an organization takes the scorecard, they receive their overall score, as well as their score in each of these 6 sections, which helps them to then evaluate how they're doing in these areas, as well as strategically plan what practices to add based on that section score. Additionally, we do provide a breakdown of how each question is scored, and the scoring is based on research and expert review, and therefore can provide organizations with important information on how to possibly prioritize the practices they plan to start. So the scorecard practices and the weight of their score in version 5, like I mentioned, is based on research. And HERO performed this research using the scorecard version 4, so the previous version. And in 2020, published 2 research articles. The first relying on formal statistical analysis on data collected from roughly 850 organizations that completed version 4, like I mentioned. And 4 clusters of practices emerged from this factor analysis and were grouped into the following categories, as you're seeing on the screen here: organizational and leadership support, incentives, program integration, and program comprehensiveness. All 4 categories of practices were found to have a strong, statistically significant effect on scorecard completers' perceptions about the effectiveness of their workplace health and well-being initiatives. And findings were published in January of 2020 in the Journal of Occupational and Environmental Medicine. And then a follow-up study lead author on it with Jessica Grossmeyer, who I believe is on this call, or I saw her earlier. So thanks, Jess, for joining us. This study was conducted to test which of the 4 categories of practices were most highly predictive of health and well-being outcomes, and specifically program participation, health and medical cost impact, and employee perceptions of organizational support for health and well-being. The findings from this research were published in the May 2020 issue of the American Journal of Health Promotion. And while incentives practices were significantly predictive of participation in health assessment survey and biometric screening completion, the organizational and leadership support practices emerged as the most predictive of all study outcomes, including participation, health and medical cost impact, and employee perceptions of organizational support. So therefore, as organizations look to improvement opportunities of their health and well-being initiatives, the scorecard will help them to identify the practices associated with stronger effectiveness. So again, really being used as an educational planning tool. I provide this slide because this is what you get when an organization receives when they submit their scorecard. They're going to get an instant report to their email, which provides a breakdown of their score by section and their overall score. It also provides a comparison to the national average and industry size, and soon for version 5, we'll be including industry type. This report also provides recommendations and resources for the organization to use to plan for improvement opportunities. After receiving this report, we recommend the following steps outlined here. So first, compare your section scores to the maximum points for each section. Review your submitted scorecard responses to identify strengths and gaps in your programs. Identify the practices associated with stronger effectiveness. Review improvement opportunities with stakeholders, and create a plan to implement and evaluate your efforts. And this could include taking the scorecard annually. So staying with our safety theme, let's now say that the organization takes the scorecard and wants to focus specifically on safety. Well, there are multiple ways in which safety is assessed in relation to health and well-being within the HERO scorecard that can help organizations both plan their safety programs as well as evaluate their initiatives. In the strategic planning section, the scorecard asks if occupational health and safety data, including injuries, accidents, workers' compensation claims, data are used in the strategic planning of a company's health and well-being initiative. In the organizational and culture support section, the scorecard inquires about written policies that support safety, the physical work environment supporting safety, and having a disaster preparedness plan that includes manager and employee training that supports employee safety. The measurement and evaluation section asks whether safety data are collected and used when evaluating health and well-being initiatives. And then lastly, the program integration section of the scorecard includes a question on how an organization's health and well-being initiative is integrated with their worksite safety program, with multiple response options, including safety and injury prevention are elements of health and well-being goals and objectives. Health and well-being elements are included in the worksite safety program. Safety data are combined with health and well-being data for identification, reporting, and analytics. And transparency is encouraged in reporting accidents, injuries, or safety risks. Using data from version 4 of the scorecard, Colleen Seringer of Alliant, who is the co-chair of our research studies subcommittee, along with HERO, published a commentary on the importance of the health and well-being and safety program integration. This report showed that 39% of the scorecard completers, and there were about 1,027 companies that were a part of this analysis. So of those completers, 39% do not integrate their health and well-being safety programs. 16% do not have a safety program. 43% integrated health and well-being safety in at least one way that is measured within the HERO scorecard. And finally, 41% of the responding organizations report that conversations are still being had centered on obtaining leadership buy-in to build an integrated initiative. Further, in this same commentary, it looked at the value of integrating safety and health and well-being initiatives. Again, this is self-reported data from version 4, but it showed that when health and well-being and safety initiatives are integrated, organizations experience an uptick in employee program participation, which could potentially impact downstream outcomes such as health risks or medical cost trend. This analysis also compared organizations whose leaders believe that health and well-being is connected to the broader business results and integrated their health and well-being safety initiatives to those that have, or to the organizations that have leaders who still believe that health and well-being is connected to business results, but did not integrate their health and well-being and safety programs. Among both groups, we saw equal participation rates in health risk assessment and biometric completions. However, there was greater participation in lifestyle coaching when leadership actually integrated the two programs, or when leaders or those organizations integrated the two programs. Further, and what you're seeing here with this figure, the organizations whose leaders believe health and well-being is connected to broader business results and also integrate safety with health and well-being. Greater than 50% of these organizations experience health risk improvement, and greater than 61% experience medical trend impact. And these outcomes were substantially better than those in organizations whose leaders believe health and well-being is connected, but do not integrate programs, where only 32% achieved health risk improvement and 44% realized medical cost impact. So that's all I have for you. Paul, I'll turn it back over to you for questions and polling.
Terrific, Mary. Thanks a bunch to both of you. And I'm going to start right off with a poll that just asked the group what their tendencies are in terms of planning. Do you have a planning approach that's really quite formal, that uses a specific strategic planning tool like Pre-Seed Proceed that Andrea presented, compared to, yeah, we do planning, but it's a little more ad hoc. We don't have a formal process, or we only plan occasionally, or we don't do strategic planning at all. Well, we're waiting for those answers to come in and have some reactions to that. Andrea, I can't help but stay on applying your expertise to safety about our current day agitation that we're all feeling around vaccine hesitancy, and that as the safety issue of the day for the private sector, as they're trying to balance, I think, education and persuasion against policy, against regulation and downright mandates. And midway through your presentation, you did reflect in the seatbelt world and the child safety restraint world. This is not new territory. You've had all manner of laws and regulations and mandates that that we've passed. Back to lessons learned, and Francis Collins sort of regrets that he didn't do more research funding on the communication side. Do you have any high level sense of the balance that we are or aren't getting right between just getting after regulatory solutions compared to education and persuasion? Or is it back to, well, we need the full Pre-Seed Proceed recipe to be able to answer that question? What's your sense of the balance right now in our culture?
Yeah, everything has turned into such a political debate. I'm constantly just shaking my head when kids have been getting mandatory vaccines forever to go to school, and people have not so many objections. People stop at red lights. People wear their seatbelts. So, I mean, at this point, it seems like we need local strategies to work their way up, because it's just so interpersonal right now.
Yeah.
And Pre-Seed Proceed would say, talk to your audience, but when your audience is the country, you got to break it down.
Got it. Yep. Yeah, you're co-author Larry Green, in an interview he did with me on the Journal, said that very same answer, that when we get stuck at the policy level, at the federal level, and by the way, not to make everybody here nervous, but your lead co-authors, both Larry Green and Marshall Kruder, I noticed they're also on the webinar, so I invited them out, see if they could stump Andrea. And
No, no.
so far they haven't stumped you because you answered just the way Larry would have. Mary, let's look at this result. We've got most of our folks say, yes, they plan regularly, but they don't use a formal planning process like pre-seed proceed. I was glad to see about 30% do have a process, not necessarily pre-seed proceed. And then only a few said we plan occasionally. As the data geek, you and Dr. Gielen are, what's your reaction to sort of the ad hoc, we'll just kind of figure it out as we go, and how do you teach your students about using tools versus winging it?
Well, I'll first say that the response didn't surprise me. That's what we're seeing with the scorecard as well. And actually, I guess if anything is surprising, and I don't actually know how you phrased it when you took it away from me, but we are seeing that people are maybe not doing it regularly either. Like it might not be an annual thing when we look at the scorecard. And so I think it's really important to become educated in these frameworks. And as Andrea's did so well today, explaining this to us and the importance of it, I think it's going to only help make improvements in your programs and then see the outcomes that you're looking for too.
Yeah. So I've launched another poll, and I totally appreciate that these are not mutually exclusive. The answer is probably all of the above, but just to get a sense of the leanings of the group, Mary, Andrea, I'm asking them, what's the best way to develop and enforce safety policies like vaccines or masks or hand washing? And so their choices are, leaders really need to step up. Joe Biden tried to step up, and the rest of the leadership in Congress said, well, wait a minute, mandates aren't what a lot of people prefer. Use choice architecture. Andrea, you brought up a couple examples. Because of pre-seed proceed, you came to systemic environmental change as a way to make it easier for people to make the right choice. Majority rules, one of my favorite books from 20 years ago is called Free to be Foolish, contrasting America with the rest of the world in terms of our, again, you alluded to our liberties as a culture, Andrea, compared to marketing and communications. Just to stay on this topic of the day, one of the editorials this morning was, I'm furious at non-vaccinated people. I appreciate neither of you are experts in smoking, but it's impressed me that at the time that the science was clearer about the impact of secondhand smoke on the rest of the room or in the house, that's the point at which it tipped in terms of saying, from a policy standpoint, sorry, you don't get to smoke in public anymore. What do you think needs to tip in terms of, it kind of feels pretty similar to me that people come in and get to breathe all over me with their unvaccinated breath. How is that any different than trying to create cancer in public environments with your smoking? What needs to tip? And Andrea, let me start with you again as a systems thinker and bringing everyone on board. What can science do to help us answer this question?
Well, you'd like to think that more evidence is going to convince people, but I mean, if you look at the tobacco example, that was probably the tipping point, but there were so many other things going on to support that tipping point. And it's such a good question. I really want to think through what are the equivalent other things that we need to have in place. You need leadership, you need community support, you need so many other things. But it's great to think about that. I think that is the way to go.
Hey, Larry headed up the tobacco initiative at CDC back around this time that we changed the regulation for the nation. And I think he's publicly said he basically left CDC because they weren't paying attention to what he wanted to get done. So Larry, jump into the chat if you've got an answer here. But Mary, let's look at the poll results here. The best way to develop and enforce policy. A lot of people said, well, leaders just have to step up. Maybe this is a time for not worrying about your popularity and just sort of do the right thing. A lot of people are saying that 47%, but most here are saying we've got to figure out better choice architecture. We've got to kind of change environments. How does that strike you in terms of the priorities for getting after policy change?
Again, I think the leadership support or the leadership stepping in as you have it here, we see that that's really, really important. It's starting from the leaders. So I would have to agree with that. The one thing that what you had was marketing and communications, and there was something in the chat. And wouldn't it be so great to start seeing, or we all bet on the first commercial of the Super Bowl. Wouldn't it be so great if that was what came up? I'm hoping for it. And I also, in communications, and I'm just thinking about behavior change in general here, maybe not at the organizational policy level, but as people become educated and maybe are becoming educated from loved ones or really people they trust, I think that's really important in changing safety behavior, especially around vaccines right now.
Yeah, got it. Andrea, you'll see I'm underway with another poll for our audience. Health professionals are well-equipped, health promotion professionals well-equipped to facilitate the organizational culture change. Here I'm asking them specifically about employee safety, because Mary just showed some HERO research that she and colleagues had done that said we don't integrate these very well, that most of the folks that come to HERO are not safety experts, they're health and well-being experts. Some of them come out of the HR world, some of them are specifically trained in public health or health promotion. Let me go ahead and share these results. We've got not as many in as I usually wait for, but I think the pattern is pretty clear here, that we're kind of all over the map here, Andrea. We're saying, most of us are saying we disagree, that we don't feel well equipped, at least in this audience on this webinar, to facilitate culture change in the workplace. Actually, if I combine those that agree, we have about a good amount that agree as well, probably a better amount. But again, it's a mixed finding here. When you think about Mary's findings that the private sector has not done very well at integrating safety and well-being, can you reflect on what we're missing because of that? And again, if you were czar of the NIOSH, what would you be pushing for in terms of integration?
Another great question. I was thinking about that when Mary showed the data, and I was thinking that keeping people safe on the job is like a little bit different than keeping people from getting injured generally. And I'm wondering if there's any opportunity. I mean, that's definitely important to do, both the health issues and those job, safety on the job issues will be responsive to the same things that any pre-seed analysis would suggest, right? You would still look at predisposing, reinforcing, enabling factors for all of those things. So it's possible to integrate them using that same kind of planning tool. But the thought I had, or the question I had was, isn't injury considered under health? And maybe one way to begin to integrate it more is if the idea of injury and safety gets talked about under health and health promotion, because people can get injured at home. They can get injured on the way to work, walking or riding.
Yeah, our time is coming to a close. It always flies so fast when we're having fun, but you actually led me into the last quick question I had for you, Andrea, given your expertise. Our next HERO think tank for our HERO members is called Changing Boundaries, Changing Benefits, How the New Ways We Work Are Affecting People's Well-Being. And one of the questions I wonder if your area of expertise is studying much is how safety dynamics are changing given the proportion of people working from home. Are we worried that they're going to have more hazards, or do we feel like there might be less hazards, especially among the thought working crowd? Is there any sentiment that's emerging so far?
Well, one thing we did was we did a national survey of people during the pandemic and compared in-home injuries that happened during the first 3 months of the shutdown with a similar 3-month period prior to the pandemic. And we actually found a very doubling of the reported injuries at home. So
Wow.
now we don't know whether those are worker related. And the questions we keep getting are these overuse injuries because we don't have ergonomic equipment at home and we're doing 10 other things while we're working at home? So it's a huge question that really needs some better attention, because like you said, the point you make is true. The workplace is so different, and it's not going to probably go back to what it was. Do you think?
Yeah, no, that's why we're doing a think tank. We don't think so either. So Mary Imboden, our director of research, I think Andrea just gave you some marching orders here in terms of our research agenda for HERO in the private sector and how it'll interact with some of these issues. Andrea Gielen, thank you for joining us, and congratulations.
Thank you.
After 3 years of working on health promotion planning with Larry and Marshall and the team, congratulations. It's going to come out in February. And so thank you for your good work. Thanks to both of you for joining us today.
Thank you.
Thank you, everyone.
Bye-bye.